Good afternoon. Hello. Welcome to this afternoon session. We've got a very important topic here on perioperative care in thoracic surgery. I'd like to welcome you all to this. It's a very exciting webinar session we're having in a great meeting. Please remember to submit your questions via the written chat. It's very important so we can have as much dialogue as possible. I'd now like to ask the first speaker to start, and this is Matthew South, and on the topic of improved bed utilisation and cost-saving impact of a specialist nurse-led ambulatory chest drain clinic. Matthew.
Hi everyone, I'm Matthew South, one of the Junior Clinical Fellows at Wythenshawe Hospital in Manchester. I'm going to briefly talk to you today about the impact of our specialist nurse-led ambulatory chest drain clinic, and in particular, how this clinic impacts our bed utilisation and its cost effectiveness. So, some quick background on the topic. Prolonged air leak following lung resection is one of the most common post-operative complications. This has a knock-on effect of increasing patient length of stay and also increases risk of further complications such as empyema. In patients who are otherwise medically fit for discharge but still have an indwelling chest drain, we can discharge them with close follow-up from our nurse-led drain clinic. So we decided we would retrospectively determine how many inpatient days were saved due to this clinic and calculate the cost benefit. So to give you a better insight of what the nurse-led clinic here does, it's not a new clinic. It's been running in some shape or form for roughly 20 years and has adapted over time. It runs 9 to 5, Monday to Friday. This includes a drop-in service where patients can contact the thoracic specialist nurses over concerns that they may have and get a same-day review if required. It performs many functions, including seeing pre-operative patients, performing COVID swabs for elective admissions in the current climate, providing a pathway for patients to receive blood and chest x-ray post-discharge if that was required. And in terms of the drain clinic itself, the patients come in the morning, which allows clamping of the drain and an x-ray if this is required. The thoracic nurses fill out a standardized proforma when reviewing these patients, which is kept in the electronic record and can help guide management decisions. If required, the advice can be sought from the thoracic registrar on call or one of the named consultants. So in terms of the methods, all patients discharged with a drain from October 2019 to the end of September 2020 were included in our review. Notes were reviewed from the electronic proforma to identify how many days post-discharge the drain was in for. Costs for an inpatient bed day and costs of an appointment at the clinic were obtained from our senior management. So here is an example of the electronic proforma the specialist nurses complete. And as you can see, it logs each part of the assessment of the drain, including whether there's an air leak or not, how much fluid has been drained, and whether the drain site is clean. And there's also a section for the management plan. So in the study period, 80 patients were discharged with a drain in situ, requiring 132 appointments in total. The median duration from discharge to the drain removal was 10.5 days, and this has amounted to a total of 1,070 inpatient days saved, with an estimated net cost benefit of over £250,000. And that was calculated with the cost of an inpatient bed day being £250 and the cost of an appointment at the clinic being £75. So to conclude, our review demonstrates that nurse-led drain clinics are highly cost effective. They can facilitate early discharge home with increased patient satisfaction. And whilst we're not specifically looking at the safety of the clinic, there were minimal complications, and this is in line with literature reviewing the safety of ambulatory drains. Okay, so thank you very much for listening to our talk, and please ask any questions.
important step forward. Have you got any idea about, in terms of your total number of thoracic surgery bed days, what percentage it was that was saved? I did see what the evaluation of how much money it saved, but how does that translate into the department activity?
So, yeah, that's a difficult one to quantify. So, one thing we didn't measure was how long the patient was in hospital prior to discharge. And then the other thing was just the assumption that, the patient would not have been discharged with a drain otherwise. So like I said, it goes down to that 10.5-day period before the drain being removed. So, obviously they've been at home, and, if they were in hospital, presumably the drain could have come out a few days earlier because it was being reviewed daily. But we had to go from that 10.5 days per patient, which totaled over 1,000 days for the 80 patients, hospital days saved.
Okay, and a sort of follow-on from that was: did you have any other drain complications at home?
So again, that would be really useful information to have, but unfortunately, this is we just had the primary outcome of the cost benefit. We didn't really look at any secondary outcomes, such as the complications that we had, how many patients needed to be readmitted. So, anecdotally, we had minimal complications, and through the literature, there's a systematic review in 2013 which looked at ambulatory bags in the context of spontaneous pneumothorax, and they had 1,200 patients, and they had no deaths. They only had 8 dislodged drains, 1 episode of local cellulitis. So, there is some evidence out there already that it is quite safe, but we didn't look at numbers for this specifically.
Okay, well, thank you very much for that nice presentation. And I think it's now time to move on to our next speaker, please.
Fantastic. Thank you very much.
Thank you very much. Okay, so our next speaker, can they please come to the to be ready? And that is selective performance of chest X-ray post-chest drain removal following lung resection is safe and cost-effective. If you'd like to go ahead, please.
Good afternoon, everyone. My name is Xiaohui Liu. I'm one of the thoracic AMPs in Southampton General Hospital. My presentation is a selective performed chest X-ray post-chest drain removal following lung resection is safe and cost-effective. The background of this study was in Southampton General Hospital, we had 4 thoracic surgeons. One of them is Mr. Azatani, and he only carried out a chest X-ray following the chest drain removal if clinical signs and symptoms indicated. The data collected was using retrospective method review of medical record in between January 2013 to December 2018, over a 5-year period. Lobectomy, bulectomy, wedge resection was included within this study, and all other thoracic procedures was excluded. There were 18 patients who fit into this inclusion criteria, and I was not able to find their date of the chest drain removal, so therefore they were excluded from this study. This is a result. As you can see, those total data was 426, and 42 of them were selected for chest X-ray, and we found that 12 of them had abnormal chest X-rays, and eventually 2 of them had a chest drain reinsertion. And in the rest of the 384 patients, we didn't select them for chest X-ray. For those group patients, we tend to monitor them for a couple hours following the drain removal, and if there's any complication, if they're clinically well, one of the AMPs will examine them, and if they're well, we can discharge them. In this study group, we found that 17 of them developed some respiratory difficulties, such as shortness of breath or dysphoria, or some of them complaining about pain. So all 17 of them ended up had a chest X-ray, and 5 of them we found that pneumothorax and surgical emphysema. So they all need chest drain reinsertion. And for the rest of the 12 patients, they had a satisfactory chest X-ray, so they were discharged. One of these 12 patients, as you can see from this slide, were readmitted 5 days after the discharge, and due to shortness of breath, and the chest X-ray showed that she had a pneumothorax, which is worse than the one when she was discharged. So she ended up with a chest drain reinserted. So in total, as you can see in this slide and in this square, there was 8 patients out of 426 patients needed chest drain reinsertion is 2%. So we found the probability of the patient need a chest drain reinsertion after the chest drain removal is very low. And this finding of this study showed that the selective approach to perform a chest X-ray post-drain removal is safe. So we recommend perform a chest X-ray after the chest drain removal only be considered if the patient has respiratory or hemodynamically instability, or following any concern of surgeons by reasoning of patient's comorbidity and findings from the procedure. I would like to propose a multi-centered study to provide some more robust evidence of this topic. If any of you interested in this topic, please contact me in person. Thank you. Any questions?
I think you're on mute, Aman.
Thank you very much for your presentation. If you're there, or if one of your colleagues is available, I wonder if you could take some questions. We've got one question that's come in, and that is, how long do you keep the patient under observation after drain removal to decide if the patient is symptomatic or not?
I may be able to answer that question if.
Oh, thank you.
Yeah, so minimum is 2 hours. They have to be sort of before they if they develop any problems within those, but at 2 hours they should be assessed and examined. Winnie, I think the question about how long before you actually assess the patients. You're on mute.
You're muted.
God, where is it?
You're there. You're here now.
Yeah, you're okay now. You're okay.
We can hear you.
Yeah, it's after 2 hours after drain removal. We review the patients, and normally when the patient after drain removal, they waited longer because they need the TTOs and all sort of nursing care and get all the paperwork ready for them to go home. So we will assess them after 2 hours basically, and then we found them clinically well and all stable. We just sent them home, signed HMRs.
Thank you. And a follow-on question from that is that, because I think people are interested in the technicalities of this, is that are the drains removed in the outpatient clinic by the nursing team?
That's I don't think that is my question, but I think that was a previous for the previous speaker.
I'm sorry. I think you're absolutely right. Well, I do have a question, because this is a very important point that you've raised. How many units across the country are using this? Do you know?
Are using this? You mean the technology?
Yeah.
You mean the routine chest X-ray?
Yes.
And this is the thing, if you see the last bit of my presentation, I would like to carry out a multi-centered study if I could, but that was my plan, and I have been talking to Ms. Atani about this, and this is in my process to write the letter to send out to other centers.
Yeah, well, I think it's a very important step forward, and there's a lot of benefits in terms of speeding things up and reducing number of chest X-rays. So thank you very much. Sorry about the little technical difficulty. Thank you. Okay, so if we could now start to move to our next presentation, which is predicting post-operative pulmonary complications in thoracic surgery, validity of the ARIS-CAT score. Thank you.
Thank you for attending my presentation on predicting post-operative pulmonary complications in thoracic surgery, validity of the ARIS-CAT score. My name is Adam Mohammed, and I will be presenting on behalf of my colleagues in University Hospitals Leicester NHS Trust and Nottingham University Hospitals NHS Trust. The incidence of PPC varies from 4.8% to 54.6% in the literature in patients following lung resection. This variation is due to differences in practice, patient demographics, and in outcome measures. Furthermore, developing PPC following thoracic surgery is known to be an independent risk factor associated with increased mortality and morbidity. Risk stratification tools currently in use aim to identify patients at a greater risk of developing both intraoperative and postoperative complications. These can include ASA, Charlson Comorbidity Index, and ARIS-CAT. Now, while ASA and CCI were not designed as tools to predict postoperative complications, there's evidence in the literature to support that they are predictive of risk. Now, our study aim was to assess the ARIS-CAT scoring system in predicting PPC in a cohort of thoracic surgery patients who had undergone lung resection. ARIS-CAT is a predictive index developed in 2010 in a prospective multi-center study. In this study, patients given certain anesthetic were randomly selected and followed to assess for development of certain adverse postoperative outcomes. Regression analysis was then used to develop a set of preoperative variables in order to create a scoring system to stratify patients into risk groups for PPC. ARIS-CAT first underwent external validation in 2014 by Matzo and colleagues. The study found ARIS-CAT to be predictive for risk of PPC development. However, the study was in a large cohort of patients undergoing surgery in multiple specialties, with only 2.8% undergoing thoracic surgery. Therefore, there is scope for validation which is specific to a cohort of patients in thoracic surgery only. Notably, there is some validation of ARIS-CAT amongst other single specialty cohorts, which is described in the literature. ARIS-CAT parameters include age, preoperative oxygen saturations, recent respiratory infections in the last month, preoperative anemia, the type of surgical incision used, the duration of surgery, and whether it was an emergency procedure or not. The score from each parameter is tallied to give an overall score used to classify patients into risk groups. A score of 25 or less is low risk, 26 to 44 being intermediate risk, and 45 or greater scoring high risk. Notably, most patients undergoing thoracic surgery will score intermediate or high risk. We conducted a retrospective, single-center observational study conducted at the Department of Thoracic Surgery in Glenfield Hospital in Leicester. Patients who had been operated on between November 2019 and February 2020 were retrospectively identified from electronic records, and they were given a clinical diagnosis of PPC where appropriate. ARIS-CAT, ASA, and CCI scores were calculated for each patient. High-risk scores were greater than 45 for ARIS-CAT, 3 or greater for ASA, and 6 or greater for CCI. This allowed comparison between a dedicated score in ARIS-CAT against routinely used classifications of patient risk in order to predict adverse outcomes. A total of 115 patients were identified for the study. The mean age was 66 years old, with 42% of patients being male. 24% of patients were never smokers, and with regards to comorbid status, 24.3% had COPD and 30% had diabetes mellitus at the time of operation. Of a total of 115 patients, 33 developed PPC and 82 did not. This equates to 29 and 71% respectively. 20% of patients were classified as high risk by ARIS-CAT, compared with 85% for ASA and 46% with CCI. The area under the receiver operating characteristic curve also shows the highest value for ARIS-CAT. This indicates that the probability of having a randomly selected patient who developed PPC having been classified as high risk was most likely for ARIS-CAT compared to ASA and CCI. IRIS-CAT also demonstrated an impressive specificity of 87.8% in our cohort. It outperformed CCI in all metrics apart from sensitivity. However, both scores performed poorly in this metric. ASA showed a sensitivity of 100%, but this is explained by the large number of patients falling under the high-risk score. The PPV of 33.67% demonstrates that the high sensitivity can be explained by the large capture of patients who scored ASA 3 or more. However, the low sensitivity of 39.4% means isolated use of IRIS-CAT would risk missing at-risk patients for PPC. To conclude, our study demonstrates that IRIS-CAT outperforms ASA and CCI as a predictive tool for PPC following thoracic surgery. Specificity for IRIS-CAT remains high with poor sensitivity. Due to low sensitivity, the risk of missing at-risk patients using IRIS-CAT is present. We have demonstrated that it is a tool with potential for further use in preoperative assessment for a stratification of post-operative pulmonary complications. Thank you very much for listening. I now invite any questions you may have.
Hi, thank you very much for that very interesting presentation. I really liked it. I'm going to ask what might be a slightly challenging question. And I think that such a score is useful, as you say, in predicting post-operative pulmonary complications. However, we as thoracic surgeons and our teams are very good at managing those. To what extent does it predict other complications, length of stay, and mortality?
So with regards to that, we didn't necessarily measure the length of stay with regards to our patient cohort. So I couldn't answer that with regards to our patient cohort. And we had low mortality in our entire thoracic cohort in that time. So our study probably wasn't powered for that. I would find it difficult. I mean, you said it's a challenging question. I don't think I probably have a good answer for that at the moment, I'll be honest.
Okay, no worries on that. There's a question that's come in from the audience, and how would you change your management of these patients based on the risk stratification?
So I think early identification of high-risk patients, knowing that they're more likely to present post-operatively with a pulmonary complication, adds to the consideration of surgical approach, intraoperative management of risk of the patient, and post-operative escalation of care. For example, patients that should be flagged early to a HDU bed, patients that should be looked after more closely with regards to their risk post-operatively, and higher escalation of care as well, and quicker escalation of care.
Thank you for that. I'm just checking to see if we've got any more questions. Do my co-chairs have any questions for you? Sorry, Ed, were you going to say something? I realise you're the senior author on this, so thank you for the presentation from your team.
No, not at all. So Adam's done a fantastic job. I think we've done some analysis that we've not presented that essentially validated clinical diagnosis of pulmonary complications as the reference point, and that is associated with lengths of stay. As Adam said, unfortunately, the sample is too small. I'm not sure if any of our other colleagues have any other questions. Obviously, it's not fair for me to be asking them at this point.
Okay, well, Adam, thank you very much for that very nice presentation.
Fantastic.
Thank you.
I'll now hand over to my co-chairs to take on the rest of the session. Thank you.
So, following three excellent presentations, it's a pleasure to introduce our next one, which is by Matthew Smith. Are routine outpatient chest X-rays following lung resection necessary? Thank you.
Good afternoon. The background to our abstracts. In the pre-COVID era, a routine practice was to perform face-to-face outpatient reviews, and we performed chest X-ray on the day. These tended to occur 2 to 6 weeks following lung resection, dependent on consultant preference. In the COVID era, as part of the wider changes, we switched to routine telephone clinic. This resulted in the loss of us performing our routine chest X-ray. The objectives we had were to compare the outcomes of the first post-operative review in each of these periods, assessing the impact of the change in practice with particular emphasis on the loss of chest X-ray. And this would hopefully guide future decision making on how we carry out our initial follow-up appointments. This is retrospective case note review of the electronic patient records, letters and radiology. And to emphasise, the patients that we looked at were lung resections for cancer. There were 3-month periods in each cohort as detailed. Results. The pre-COVID cohort, 82 cases and any readmissions were reviewed. Just over half were seen locally in Liverpool, with around 40% seen at peripheral clinics. There were some, no record of follow-up was found, which were likely peripheral clinics with letters not received. 98% of the consultations were face-to-face. Chest X-ray was performed routinely in 80% of cases. In terms of outcome of the routine X-ray, over 90% were considered satisfactory, no action taken, and the patients placed under routine surveillance follow-up thereafter. 4 revealed a finding, which came in at 6.7%. 2 of these, tiny pneumothorax, tiny effusion, no action was deemed necessary. And in 2 cases, repeat chest X-rays and repeat review were performed. We had 4 readmissions in this period. In the post-COVID era, 82 cases again were reviewed. Some patients didn't receive follow-up. We had 2 deaths in the period. 1 had a lengthy readmission with us over the follow-up period. And 2 patients, because they were discharged on flutter bags, had been seen serially. 92% of the consultations were now via telephone, although the remaining 7.8% were recalled face-to-face at the request of the patient, and the majority of these did have an X-ray. In terms of the outcomes, 97.5% were placed under routine follow-up. 2 were felt to warrant a face-to-face review after the telephone consultation, and X-rays were performed in both these cases. 1 subsequently had a chest infection, 1 wound infection. In this period, we again had 4 readmissions. 3 occurred prior to any planned follow-up. In terms of our key findings, in the pre-COVID period, not all patients got a routine X-ray anyway. Only a small percentage of these X-rays were felt to demonstrate any finding. And half of these patients did have a repeat X-ray, but no real change in management. And certainly none were felt to have significant changes in management. And 6%, as detailed, were readmitted. But none of these of importance had any chest X-ray abnormalities, or were felt these could have been avoided. In the post-COVID period, high percentage progressed onto our routine follow-up thereafter. 2 patients were reviewed again after the telephone consultation and received a targeted chest X-ray thereafter. Management changes initiated, and the patients had a good outcome. Again, with the readmissions, on thorough review of the notes, none were likely to have been avoidable had they had a routine X-ray. So in conclusion, we suggest that a routine 6-week follow-up X-ray after lung resection is not worthwhile. This is low yield, and resources may be better utilised elsewhere. And the new strategy of a target X-ray, when indicated, is a really valuable alternative, and certainly appears safe enough to continue to trial that approach, keeping it under review. And this work may aid our decision making when we're deciding whether to continue telephone-based follow-up in the post-COVID era and recovery phase. Thank you.
Matthew, thank you very much for a fantastic talk, and congratulations to you and to your colleagues in Liverpool. I think it's fantastic that you took COVID, which was very challenging, and looked at your practice to see how it could influence the future. And I think that's really key as we move out of the pandemic. I have a couple of questions whilst we wait for some from the audience. In the pre-COVID group, 80% of your patients received a chest X-ray. What was the reason for the 1/5 that didn't? Was that intentional, and was there anything different about that subgroup?
Well, I think there was some variation between consultants and perhaps the registrars that had been allocated to the clinic. It had perhaps been creeping in the idea that an X-ray every time was not that valuable. So that was my feeling.
Okay, and similarly, what's your understanding of the patient's perspective on this? So definitely in our patient group, they do value that they've had a chest X-ray. It is maybe falsely, but reassuring. How did you convey this change in practice to patients and reassure them, especially if you had any patients who were second procedures, for example?
Certainly, I think part of the reluctance to not perform an X-ray is our feeling that yes, it is very reassuring for us, and we can reassure the patient if the X-ray is indeed satisfactory. So that was another reason to look into this. In terms of reassurance of the patient, I think a lot of these patients, particularly after lung resection, have not been there before. If they are reassured in other ways, they will feel satisfied with that outcome. But in reality, a lot of them aren't going to have anything to compare to. With the I think sometimes perhaps the routine X-ray was a remnant from when follow-up was done with X-ray, but obviously with that now being CT based in general, it's perhaps less vital to have a baseline X-ray compared to as well.
Brilliant. And your presentation sparked a couple of questions from the audience, so fantastic. I'll link both together. I think the question is it a natural next step to have the telephone follow-up facilitated by AMP colleagues to free up clinician and trainee time? And secondly, have you separately looked at patient satisfaction with the telephone method?
So in terms of the first part of that, I suspect for the first post-operative review, when it's often a case of delivering results, explaining any adjuvant therapy or referrals that are suggested. I think in Liverpool, it does tend to be a medic that's seen them in that instance. We are running nurse-led follow-up clinics, and that anecdotally seems to be growing and expanding. But not perhaps for the first post-operative consultation. And there, I'm sorry, what was the second?
And the second one was with regards to patient satisfaction with the telephone method of delivery.
Thanks. So I've not looked into that yet. I mean, I think it's going to be really key, isn't it, in deciding whether we continue with telephone or remote-based follow-up. What the patients do actually think. So yeah, getting some data on this will be useful. It's not been the subject of this review, but it seems to work extremely well for the 3 years down the line lobectomy. Had a satisfactory CT last week. Patients well. That phone call seems to work excellently. But I think in the setting of the first post-operative visit or review, it may be a bit less clear-cut what the patients do prefer.
Fantastic. And I think we have some colleagues over here who are working on some data similarly, so we look forward to seeing the results of that. Matthew, thank you very much.
Thank you.
I'll take the opportunity to introduce the next speaker, Guy Xus. I do apologize if I've mispronounced that, who's going to be talking to us about the utility of perioperative bronchial alveolar lavage in thoracic surgery.
Good evening.
Thank you for giving me this opportunity to give this presentation today. My talk will be about the utility of perioperative bronchoalveolar lavage and thoracic surgery. Chest infection in thoracic surgery is considered one of the most common complications, and that can increase the mortality and morbidity rate. Also, that can lead to postponing of the adjuvant treatment if it was indicated, and it may increase the length of hospital stay. So we aim in this study to evaluate the benefit of perioperative bronchoalveolar lavage and the effect on postoperative chest infection and how it can reflect on the length of stay. Bronchoalveolar lavage is a diagnostic method of the lower respiratory system in which a bronchoscope is passed through the mouth or nose into the appropriate airway in the lungs with a measured amount of fluid introduced and then collected for examination. This is a retrospective study including 194 patients who underwent different thoracic surgeries. Patients were divided into two groups. The first group, it's the standard group, included 94 patients, while the second group included 100 patients who had perioperative bronchoalveolar lavage. The procedure, perioperative flexible bronchoscopy, was performed during intubation immediately before the surgical procedure. Initially, an inspection of the bilateral bronchial tree to evaluate for any endobronchial lesion, tumor invasion, or secretion. Then a 50 cc of normal saline was injected in each side and aspirated again. Accordingly, 2 samples from each side were sent for analysis, one as cytology and another one for microbiology analysis. Moreover, suctioning of any secretions in the bronchial tree was done during the procedure. In the results, we see that chest infection, it was significantly lower in group 2 with 11% comparing to group 1 with 22.3%. Also, the length of stay was significantly lower in group 2 with 5.6 days comparing to 9.4 days in group 1. Univariate analysis was performed in variable that may affect chest infection, which showed that absence of lung disease, group 2, patients who underwent bronchoalveolar lavage and non-invasive approach are significantly decrease the risk of chest infection. Multivariate analysis of these factors showed that they are decreasing the risk of chest infection, but without statistical significance. On the other hand, lung disease and groups were analyzed in correlation to length of stay by linear regression as multivariate analysis, and both were significantly decreasing the length of stay. Ira et al. Did a retrospective study that included 121 patients who had open lung resection for lung cancer. They evaluated the relationship between positive intraoperative bronchial culture and postoperative lung infection. They found that 88% of patients with positive culture developed a lung infection during the recovery period. The multivariate analysis revealed that positive culture is an independent factor for development of lung infection postoperatively. The strength of this study that it's discussed the utility of perioperative bronchoscopy as a prophylactic procedure to prevent postoperative chest infection in thoracic surgeries. Our results show that this approach decreased length of stay. Moreover, it's not a time-consuming and safe procedure. Limitation of this study is the retrospective method and non-matching groups in surgical approach. We aim in the future to do matching prospective studies to compare our results. In conclusion, bronchoalveolar lavage decreased length of stay as shown in the multivariate analysis. More studies need to compare the benefit of bronchoalveolar lavage in preventing chest infection postoperatively. Also, it can use as diagnostic methods to treat patients with a chest infection based on the culture results.
that lead to adopt this technique in surgical practice, especially in high-risk patients. Thank you.
Thank you very much for a fantastic presentation. Just until some questions come in from the audience and from my co-chairs, from our perspective, in terms of identifying a group that are more likely to benefit from this, do you have any suggestions, or would you recommend applying it across the board?
You're on mute.
Dr. Ksus, I think you're muted.
Sorry, do you hear me now?
We can hear you now. Thank you.
Thank you for your question. So I think the high-risk patients, such as patients with COPD or patients with long period of smoking, or in general high-risk group patients, they can benefit more from this technique to decrease the amount of secretion post-op and decrease the risk of chest infection. So I think during our study, we didn't separate the groups for high risk or low risk. It was done retrospectively, and it was based on surgeon preference. One of the surgeons, he preferred to do this technique, and other surgeon, he didn't prefer to do this technique. So our groups was not separated based on the risk evaluation. But I think the high risk patients, they can use this technique, and it will be a benefit for them.
So Mr. Kunal has a question for you.
Yeah, the question is it sputum
I can
clearance?
read that, yes. So is it sputum clearance, or is it identifying the microbiology? What's your understanding of how the mechanism of benefit is?
First of all, it can be used as diagnostic technique and prophylactic technique. From the diagnostic side, for example, from that group, from 100 patients, 11 patients, they had chest infection after surgery. And 8 of them, around 87%, they had positive culture from the aspiration, from the Bronco lavage, which showed the positive culture after surgery. And we treated them based on the sensitivity for the culture. So it can also, it's useful as diagnostic approach, and also as prophylactic approach, which will decrease the length of stay and decrease the risk of chest infection and secretion.
Brilliant. Thank you very much for that. In the interest of time, we'll move on to our next talk. So I'd like to introduce Lauren Dixon, who will be speaking to us about the effectiveness of enhanced recovery after surgery protocols in elderly patients undergoing resection of primary lung cancer.
Hello, my name is Lauren Dixon. Thank you to the SCTS for inviting me today to talk to you about the effectiveness of ERAS protocols in elderly patients undergoing resection of primary lung cancer. ERAS protocols are used in thoracic surgery as well as many other surgical specialities. The evidence-based approaches are used to improve the outcomes of patients following major surgery. Here at the Bristol Thoracic Surgery Department, we use the following ERAS protocol. And as you can see, the protocol begins long before surgery in the pre-operative period. The preparations continue on the day of surgery and throughout the perioperative phase, and then finally we target the post-operative recovery. Lung resections are offered to patients with primary lung cancer as part of their management. It is already known from thoracic surgery and other surgical specialities that ERAS protocols result in better patient outcomes. And furthermore, it is known that improved compliance to ERAS results in improved patient outcomes. However, it is not known if ERAS protocols are effective within the elderly population specifically. And therefore, we aim to determine the effective age on protocol compliance, morbidity, and length of stay in patients undergoing resection of primary lung cancer. We looked at a 7-year period from 2012 to 2019 at our centre in Bristol. We included all consecutive patients undergoing resection of primary lung cancer who followed our ERAS protocol. We used prospectively collected data in the form of ERAS data that is routinely collected at our centre. And we looked at the outcomes of compliance, morbidity, and length of stay. Finally, we performed statistical analysis in the form of Spearman's rank analysis and logistical regression. During the 7-year period, 1,537 patients underwent resection of primary lung cancer at our centre. And as you can see, over half of those patients were over the age of 70, and around 10% were over the age of 80. Using Spearman's rank analysis, we found that there was no correlation between increasing age and overall compliance to our ERAS protocol. Interestingly, we found in the group of over 80 years, it was associated with a reduced requirement for post-operative intravenous opiates and an earlier return of oral intake. It is also interesting to note that in those patients with a greater than 80% protocol compliance, there was an association with reduced risk of morbidity. Using a multivariate logistical regression analysis, we found that increasing age was associated with an increased risk of morbidity post-operatively. Comparing the two eldest age groups with the under 60 years age group showed that there was this increased risk of morbidity. However, it is worth noting that the increased risk of morbidity did not translate into an increased length of stay. We defined a delayed discharge as a length of stay of greater than 5 days. Excluding patients with all morbidity from this multivariate analysis, we found that age was not associated with an increased risk of delayed discharge. From this study, we have learned that in our patients who undergo resection of primary lung cancer and follow our ERAS protocol, over half of them are over the age of 70 years. We already know that increased compliance to ERAS protocols leads to better patient outcomes, and now we know that age is not related to ERAS compliance. We also have shown that age is associated with increased morbidity, but in the patients who follow our ERAS protocol, this does not result in an increased risk of delayed discharge. Thank you very much for your time.
Thank you very much for a fantastic talk. I think it's brilliant data. It's very interesting insight. Just a couple of questions from my end. Did you have any frailty score data? And if not, do you have any plans to incorporate this? Because that might be another way of stratifying that you might find more useful.
You're on mute.
I think we should be able to hear you now. Yeah.
So this is particularly interesting, actually, to look at frailty rather than age. Unfortunately, with the ERAS data, we don't have the frailty score. So when we did our adjustments, we adjusted for things that are likely to influence frailty, such as comorbidities and functional assessment. But we couldn't, unfortunately, use the frailty score. I think going forward, that is a really important thing to look at, because we're not just using age then as a surrogate for frailty.
And you linked age to compliance and age to morbidity. What I may have missed, and I do apologize, how did the compliance link to the morbidity? Because that is the crux of the question, isn't it?
Yes. So as previous data sets have shown, our data also agreed that people who had a better compliance score overall had less morbidity, and that was significant in all of the age groups.
Fantastic. There's a question from Mr. Azetani. What performance status or NYHA descriptors were the patients falling into? And was that data available to you?
So we had ASA and we had a Thoracic score, which in our multivariable analysis we did adjust for, so that we could just kind of look at age in that way. And I think because we were our centre was quite good at selecting the patients who are in the older age groups. I think that's why we didn't see such a big correlation, because we are choosing the correct patients to undergo this type of procedure.
Absolutely, that's fair enough. Thank you very much. We will need to move on to the next speaker. So it's my pleasure to introduce Jason Coe, who is going to be talking to us about whether all patients should receive extended chemotherapy after resection for primary lung cancer. Thank you.
Hello, my name is Jason Koh, and I'm an FY2 doctor working in Oxford. Thank you for this opportunity to present our findings on behalf of the Thoracic Surgery Department of Oxford University Hospitals NHS Foundation Trust. The question is, should all patients receive extended chemical thromboprophylaxis after resection of primary lung cancer? Patients who undergo lung cancer resection surgery are at increased risk of venous thromboembolism or VTE. Factors such as prolonged operative time, older age, obesity, and pneumonectomy may increase the risk. The use of extended chemical thromboprophylaxis after major abdominal and pelvic surgery has been shown to be associated with reduced incidence of VTE compared to shorter regimens, but its role in thoracic surgery patients is not known. The Caprini risk assessment model may be used for VTE risk stratification purposes. We aimed to evaluate the safety and efficacy of extended chemical VTE prophylaxis in patients undergoing resection of primary lung cancer. We retrospectively reviewed the outcomes of consecutive patients who underwent resection of early-stage primary lung cancer between January 2013 and December 2018 to assess the incidence of VTE. In July 2016, a change in protocol from inpatient only to post-operative extended VTE prophylaxis with 28 days of dalteparin was instituted. Diagnosis of VTE, which includes both DVT and PE, was made on either ultrasound Doppler, CT-PA performed due to clinical suspicion of PE, or routine post-operative follow-up CT chest, abdomen, and pelvis at 6 months. We calculated our patients' Caprini RAM scores retrospectively. Exclusion criteria were patients on pre-operative and post-operative long-term anticoagulation with either DOACs or warfarin, patients lost follow-up, post-operative death not due to VTE, and patients whose interval CT scan exceeded 9 months from the date of surgery. We performed chi-squared and Fisher's exact test to compare categorical variables and Mann-Whitney U test to compare continuous variables. A logistic regression model was carried out to identify independent risk factors associated with VTE in our cohort. We identified a total of 750 consecutive patients during our study period. After applying our exclusion criteria, 600 patients remained for analysis, 297 in the control group, patients receiving post-operative inpatient thromboprophylaxis, and 303 in the treatment group, patients receiving extended thromboprophylaxis. We summarize our patient characteristics and demographics in this table. We observe a similar distribution across the variables in both groups, with the majority of our patients having medium to high Caprini scores. We demonstrate an overall reduction in post-operative VTE events by 2.4% and a significant reduction in PE by 3%. 11 VTE events in the control group were PEs, 6 of which were within 28 days of the post-operative period. In the remaining 5 patients, 1 developed PE at 3 months and 4 at 6 months. In the treatment group, 4 VTE events were recorded. 1 PE and 1 DVT were within 28 days of the post-operative period. The remaining 2 events were a PE and a DVT at 2 months and 6 months respectively. There was an overall reduction in VTE events within 28 days of the post-operative period. These findings suggest that the critical role of extended thromboprophylaxis may be during the first 28 days after surgery. We also observed a reduction in VTE-associated death. 1 patient in the treatment group developed upper gastrointestinal bleeding whilst on extended dalteparin 10 days after his operation. Our multivariable logistic regression model suggests that other or mixed histopathology subtypes of lung cancer, longer post-operative stay, previous history of VTE, and post-operative lower respiratory tract infection are independent risk factors for post-operative VTE. In conclusion, lung cancer patients who undergo thoracic surgery are at risk of VTE. Moderate to high Caprini scores are seen in up to 99% of patients. We have demonstrated that extended chemical thromboprophylaxis is safe and feasible and should be considered post-operatively. While the Caprini model may be useful, it would need further validation in our thoracic surgery patients. More studies to investigate the true efficacy and optimum duration of extended chemical thromboprophylaxis are still required. Thank you for your time and attention, and I'm happy to take questions.
Oscar, thank you very much for a fantastic talk. A couple of questions focusing around the use of risk stratification. So there is good data from a couple of US centers, and actually one of ours in the Midlands, that shows that actually the Caprini score is got good discriminability in terms of the risk factors. In terms of informing your decision-making to give extended trauma prophylaxis to all patients, what was the rationale underlying that? And as a follow-on question, did you perform a secondary analysis to look at whether your events were in the high or in the moderate Caprini risk group?
So to answer the first question, I think we didn't really, it was more of just introducing the protocol and see what results we achieved from there. There wasn't really evidence-based per se. I mean, we do know, and I think, as a thoracic surgery audience, we have lost patients to post-operative VT events, and we recognize that this is a post-operative complication that potentially could be preventable if we gave post-operative dalteparin. I think lung cancer belongs to a group of malignancies that's very difficult to predict VT events, whether or not it's related to surgery. I know that from certain studies from the American studies, for example, they have looked at using Caprini scores to tailor their approach to VTE prophylaxis. Again, their studies are sort of focuses on quite a small cohort of patients. I think it's really difficult to actually say whether the scores, we can definitely tailor our patients' VTE prophylaxis based on those scoring systems. And I think there still needs to be further studies to evaluate that. The second question about, sorry, just remind me what the second question is again.
So I think I can link it into one of our co-chair's questions. Mr. Azatani is asking whether you've looked at the protocols being used in other specialties, and I'll add another follow-up onto that in terms of whether you'd considered using alternatives to low molecular weight heparin.
So we have not looked at specifically at what other surgical specialties do. I mean, certainly we do know that in our orthopedic counterparts and general surgery counterparts, there is a huge push towards using extended thromboprophylaxis after operations. And we do know that there is positive results from it, and that's why a lot of guidelines are implementing it. Obviously, there's still a lack of those guidelines in our thoracic patients. We haven't really looked at alternatives. We know that dalteparin is safe. I think the only thing that probably is sort of a downside of dalteparin is probably the cost compared to oral alternatives. The other thing as well is I think in cancer patients there is probably still a lack of studies in terms of absorption in particular, and whether sort of subtherapeutic by using DOACs compared to dalteparin. So I think it's a potential avenue in the future, but I think at present with the current evidence, probably stick with dalteparin for now.
Thank you very much, and we'll look forward to hearing more about this, especially as there's new international guidelines coming out on VTE prophylaxis and thoracic surgery. So very timely talk, and well done. I'll hand over to my co-chairs to facilitate the rest of the meeting.
Thank you very much, Edward. So we have our next speaker, who is Aus Al-Mukhtar, who is going to be talking about defining postoperative pulmonary complications in thoracic surgery, the validity of the STEP collaboration recommendations.
Hello, good afternoon. My name is Aus Al-Mukhtar. I'm a trust grade SHO at University Hospitals of Leicester. I'm here to present our research titled Defining Postoperative Pulmonary Complications in Thoracic Surgery, Validity of the STEP Collaboration Recommendations. Just a little background, that reported incidence of postoperative pulmonary complications, or PPC for short, varies from 5% almost to almost 55%. This large variation is not just due to variation in practice, but also due to different outcome measures, which are difficult to compare and therefore difficult to study. In addition to increase in mortality and morbidity associated with PPC, a prospective observational study involving almost 700 patients concluded that Post-operative pulmonary complications are an independent risk factor for late death in lung cancer patients, which highlights the significance of PPC. However, the impact of any large clinical trial is critically dependent on the use of well-defined outcome measures. A recent systematic review found 27 definitions of PPC. Most of them were poorly defined, non-objective, and too broad to be compared. This inconsistent reporting of outcomes across trials investigating a similar clinical problem hinders the interpretation of new research in the context of what we already know. It also prevents the use of pooled data and systematic reviews and meta-analyses. Therefore, a well-defined outcome measure is needed for meaningful research. In 2018, an international group of leading scientists developed recommendations for standardized outcome. They conducted a comprehensive systematic review of clinical trials and observational studies of pulmonary outcomes in perioperative setting, followed by a three-stage Delphi process. Their main focus was on producing definition which is inclusive and applicable in clinical practice in order to reduce subjectivity and to ensure a more valid comparison across studies. I will not go through the components of the STEP definition, but I put this slide to stress on that the new definition includes a measure of severity, which will significantly reduce subjectivity in evaluating pulmonary outcomes. It would also ensure a more valid comparison between studies. We conducted a retrospective observational study with the aim of comparing predictive validity of the Melbourne Group Scale, which is a validated, recognized multidisciplinary scoring tool, against the predictive validity of the STEP collaboration recommendations in thoracic surgery. We searched our electronic records for patients who underwent lung resection between November 2019 and February 2020. We calculated both scores for all patients and compared their predictive validity against the clinical diagnosis of PPC, which was set as a reference point. 115 patients were included in the study. The mean age was 66 years. 42% of the cohort were males, 24% were non-smokers. In terms of pre-operative risk assessment, 85% had an ASA score of 3 or more, and 46% were deemed to be high risk by the Charlson Comorbidity Index. In our cohort, 28% were clinically diagnosed to have PPC. We used those patients as a reference point, and by applying the MGS score to the cohort, only 5% were deemed to have PPC, while 38% were deemed to have PPC judged by the STEP criteria. Looking at the area under the ROC curve, where the y-axis represents the sensitivity or the true positive rate, while the x-axis represents 1 minus specificity or the false positive rate, you can see that the AUC for the STEP is slightly closer to 1 at 0.63 compared to the Melbourne Group Scale, which is 0.59. However, this does not give the whole picture. If you look at this table, you can see that even though the STEP definition is less specific, it is much more sensitive and fairly accurate. The sensitivity of the MGS in detecting PPC in our cohort was only 18.2% compared to 57.6% using the STEP criteria. In conclusion, this retrospective observational study shows that the STEP definition represents higher predictive validity for post-operative pulmonary complications in thoracic surgery than the MGS. Adoption will allow research to be more meaningfully synthesizable and reduce research waste.
Thank you. Thank you. Thank you, Aus. Very good presentation and relevant to our specialty. So the question will be is, would you consider doing anything prospective, considering what your findings and outcomes? This was a retrospective study. Would you plan to do a prospective one just to see whether your findings are different when you have set up this as an assessment tool?
Thank you very much for your question.
You're muted. No, still we can't hear you.
Can you hear
Your volume is still quite low, Ash.
Oh.
You're
Yeah.
pretty quiet.
Yeah.
Can you come closer to your...
I think you need to get closer to the microphone, maybe.
You're muted now.
Oh. Would you like Edward to maybe volunteer something on his behalf?
Sure, I'll allow Ash to deal with the technical problems briefly, and I'll answer on his behalf. So the short answer is yes, and I think that was the strength of the work that Babu and Paula did a few years back on the MGS. Definitely doing it prospectively would add to the validity. And this was actually one of the very early explorative analyses of using the step criteria. So there are plans to move forward with this.
Very good. And to follow up again, another question: would you consider doing this on a multi-center? We'll be interested in this if you at the stage, maybe after your prospective or alongside, if you want to expand it to other centers so you can increase the pool of patients you're doing your analysis on.
So we would definitely be very grateful for the collaboration. Again, Ash, apologies, I don't know if your microphone's fixed, but in the meantime, together with the college and with SCTS, we've had a much better trainee academic network that's been established, also with the leadership of one of my colleagues in Birmingham, and under the supervision of Eric Lim and Babu Naidu. So this could very well be one of the projects that we look to reach out for. If there are others like yourself who would be keen to participate. So I'm very grateful for the offer.
Sure. Any other questions to the group from Leicester? I know Edward is answering on behalf of House because of technical problems. Any questions? I can't see anything in the... Let me have a look at the audience. Nothing there. Okay. I think for the sake of time, message from... Okay, yes. A quick message. Visit the exhibition and do scavenger hunt, please. So let's move on to the next presentation. Thank you very much. I was sorry for the technical problems, but we just need to get on with the presentation. So the next presenter is from the Cambridge, Papworth group, Cambridge group, multi-center evaluation of renal impairment in thoracic surgery, the MERIT 1 outcomes by Vinci Naruka.
Thank you on behalf of Mr. Kunar, the Chief Investigator, and the more than 150 people and 17 centers that participate in the study of AKI post-thoracic surgery. This is one of the largest cohort studies ever conducted in thoracic surgery. Mortality and its variations in thoracic surgery are now very low, limiting its use as a quality measure. We're looking for others which are meaningful and easy to collect. AKI can be such a measure. The aims are incidence and baseline characteristics of AKI in multiple centers, explore the variations in AKI rates, explore clinically meaningful associations. We undertook a multi-center observational retrospective study, collecting all thoracic surgery cases over a period of 1 year in 2016-2017. All thoracic units were invited. Renal variables were provided by biochemistry departments. The variables collected are listed on this table, chosen after our pilot study because they are robust and easy to collect. Out of 35 thoracic units reporting to the SCTS thoracic surgery audit, 17 participated. 15,154 patients were collected, which was 52.7% of all the operations in that time period. Unit numbers range from 304 to 2,416. 58% of patients were males, 54% of patients were between the age of 60 to 79 years, 50% of cases were performed by ABATS, and 38% were open. The overall AKI incidence rate was 7.2% within the first 7 days of the operation. Most were stage 1 AKI. Unit AKI rate was between 3.1 to 16.1%. This spread was statistically significant and can be appreciated in this graph, which depicts a forest plot for AKI incidence for each unit. Point ranges report the AKI proportion of that center. The units have been listed in rank order from 1 to 17, with 1 being the lowest rate of AKI and 17 the highest. The solid horizontal line is the mean AKI incidence across all centers, and the dashed line represents the associated confidence intervals. This next graph shows adjusted forest plot for AKI incidence among different units. Orange points represent centers that deviate significantly from the average, and the black points represent non-significant centers. After adjustment, there are 5 positive and 6 negative statistical outliers, which would support AKI use as a performance metric. We found that there was significant variation in 11 of the 17 sample centers after adjusting for our observed covariates. This suggests that there was significant variation across the centers. Patients with AKI had an increased median postoperative length of stay of 4 days longer when compared to non-AKI. Patients with AKI, as compared to those without, had a significantly increased mortality at 30 days, 90 days, and 1-year mortality. Across centers, we found that mortality varied between 0.3 to 5.1% at 30 days and 3.2 to 19% at 1 year. The following are the forest plots for mortality among different units. The solid horizontal line is the mean mortality across all centers, and the dashed lines represent associated confidence intervals. Mortality significantly varied across units between 0.3 to 5.1% at 30 days. It significantly varied across units between 2 to 9.6% at 90 days, and it significantly varied across units between 3.2 to 19% at 1 year. The rank of mortality was not the same as AKI. In summary, the overall AKI incidence in our study across 17 units in 15,154 patients was 7.2%. AKI varies significantly between units. AKI variation is greater than mortality variation. AKI is significantly associated with increased postoperative length of stay and mortality. Unadjusted increase in hospital stay associated with AKI is 4,360 days, or 5.1% of the total bed stay. In conclusion, we propose that post-thoracic surgery, AKI should be included as a comparative quality measure. By reducing AKI rates to those of the best performing units, there could be meaningful clinical and health service benefits. We would like to thank all the MERITS collaborators, consultant leads, day-to-day coordinators, students, steering group, and SCTS. Thank you for listening.
Thank you very much. That's very nice, Vinci. That was a very nice presentation. We were delighted to take part in this study led by your unit, and hopefully we are in the good boxes. So any questions from the floor? Can't see in the chat. Okay. The next question, if I may ask, is would you consider sort of developing any scoring system of people looking, because you have a nice database now,
yes,
with good representative sample from around the country. Would that be something to help you now look at some sort of scoring, or to help some guidance across the country?
Yeah, no, that's a very good question. So the aim of this project was basically to show that AKI does vary between units, and it varies more than mortality. Our statisticians did do some modeling diagnostics, and they do show that it is a reasonable, it does have reasonable level of discrimination between units, the AKI itself. However, this is a retrospective study, and the next step would be to dive in deeper, trying to understand what makes some units better than other, what can we learn from them, and can we disseminate that among other units, and try to, once we have prospective data, we can then try to see whether we can incorporate AKI in a scoring model.
Edward, did you have a question?
Yeah, so Vinci, fantastic work. It's impressive output. My question was, do any of the existing models correlate with the risk of renal injury? Because obviously, one of the other questions is, are there differences between units because of differences in the patient groups as well?
Yes. I don't think we have looked at comparing other coexisting, for example, the Thoracic score or other existing models. But that's something that we can look into. I don't think AKI is not mentioned. It's not a parameter in those scoring systems at present. And that's where this whole idea took inception, where AKI does vary so much between units. Should it be incorporated?
Because particularly if you look at the urolung mobility models, that might be something you may wish, if you have the parameters, to correlate with the development of AKI. It would be very interesting to see.
Absolutely, yes. Yeah.
I think in the era now where the mortality is gone so low with the procedures we're doing, I think morbidity becomes more relevant, and I think length of stay and other sort of soft indices will become more important to track and between in the future. Thank you very much, Vinci, for a nice presentation. Well done for the unit as well, for this national study, which was really well done and well conducted.
Thank you.
Our next speaker now is Ira Goldsmith. Ira?
Ladies and gentlemen, good afternoon, and thank you for the privilege. I have no disclosures or conflict of interest to declare. Prehabilitation, or Prehab, is a broad therapeutic concept and refers to a series of services administered to symptomatic patients in an attempt to improve their quality of life. In thoracic surgery, it is a process of enhancing the functional and physiological capacity of an individual to enable them to withstand a stressful event, namely surgery, and aid in their recovery. In my presentation, I will cover why prehabilitation is required in thoracic surgery, criteria for referral, the staff and setup required to deliver a standardized structured program, assessment of patients, components and duration of the program, and outcomes one can expect on implementing this service. Why prehab? For example, in lung cancer, published literature informs us that anatomical lung resection offers the best prospect of long-term survival in patients with non-small cell lung cancer. And in view of the dismal prognosis of unresected bronchial cancer, surgical resection should be considered for every patient with anatomically resectable disease. However, we have seen that the demographics of our patients with resectable non-small cell lung cancer is getting older. In this aging population, frailty is increasingly being recognized as an independent risk factor for adverse post-surgical outcomes, namely major morbidity, mortality, and a protracted length of hospital stay following surgery. Due to their smoking habits, our patients may have smoking-related underlying cardiopulmonary disease, for example, COPD or emphysema, with reduced pulmonary function. Loss of lung tissue in such patients may grossly impair their post-surgical ventilatory function or diffusion capability, predisposing them to dyspnea, cardiopulmonary complications, and death. Hence, some patients with borderline or poor pulmonary function are considered inoperable and referred for alternative treatment or palliative care instead. For example, this 81-year-old lady, she has been a lifelong smoker, hence has significant emphysema as seen on her CT scan. She has a biopsy-proven 2-centimeter left upper lobe adenocarcinoma of the lung. She gets breathless on walking 100 yards, hence has a dyspnea score of between 3 and 4. She is capable of only limited self-care and her performance status is 3. Due to her emphysema, her lung functions are borderline to poor with an FEV1 of 0.76 liters and DLC of 45% predicted. At 81, she is vulnerable to adverse post-surgical complications and death. Her risk of death, calculated using the Thoracic score, is 5.9%. In a fit and healthy middle-aged person with good lung function, A similar diagnosis would allow that person to safely undergo a curative anatomical lung resection with a risk of death of 1.2%, and a 5-year survival following his or her surgery is over 80%. Conversely, all the factors mentioned makes the 81-year-old lady unfit for major lung resection. In other words, she is inoperable. The BTS guidelines advises us that when we assess such patients for surgery, we should identify and address any potentially modifiable risk factors and then reassess the patient for surgery. So let us look at her Thoracic score once again. Of the 9 variables used for calculating the score, we, for example, cannot change her age, gender, etc., but we can modify and lower her dyspnea score and performance status, and by doing so, lower the Thoracic score, that is the perceived risk of death, to 1.3%. So how can we improve identified modifiable variables of our patients so they can undergo diagnostic tests and treatment safely? From the literature, we know that preoperative pulmonary rehabilitation helps to significantly improve the lung function of patients, particularly their FEV1. Indeed, there is a positive correlation between improvement of FEV1 with prehab, and this beneficial effects of prehab is most emphasized in patients with initially the worst pulmonary function. With improvement of pulmonary function, there is improvement of dyspnea, and there is a similar improvement in the 6-minute walking distance with prehab. So prehab has shown to significantly improve lung functions and symptoms of dyspnea. Improving levels of activity improves the performance status of patients and frailty. And with improvement of both dyspnea and performance status, there is lowering of the Thoracic score or risk of perioperative death. And with a pilot study, we showed this was achievable with prehab. From lessons learned from a published pilot study and from published guidelines, we established a standardized prehab service at our center. The referral criteria used are dyspnea score, performance status, age, frailty, borderline or poor lung function, or on grounds where the referring physician felt the patient would benefit with prehab, including smoking cessation. A structured prehab program requires a properly equipped gym and trained cardiothoracic physiotherapists to provide patients with twice weekly 70-minute sessions of exercises, education, and assessment delivered over 3 to 4 weeks. The prehab exercises are aimed at strengthening the muscles of respiration, breathing exercises, improving diaphragmatic breathing and control of breathing, coordinating the breathing process, and retraining the respiratory muscles with incentive spirometry, which improves the strength of respiratory muscles and clearance of sputum after surgery. Effective airway clearance techniques to maintain a clear respiratory tract following surgery are taught so they can be performed 3 times daily by patients at home prior to coming in for surgery. Patients also undertake cardiovascular exercises to help improve generalized muscle weaknesses and their pulmonary mechanics. Training exercises listed are performed whilst monitoring each person's heart rate, blood pressure, and oxygen saturations, all in keeping with the FIT principles of training. As people move from one station to the next, carrying out their aerobic and breathing exercises, the rate of perceived exertion is used twice at every session to measure the intensity at which people are working and to guide them to increase or decrease their effort as required. This provides a direct feedback to the patients to tailor the exercise program according to their needs and participate in their own rehabilitation program. The Cavonan formula is used for calculating each person's heart rate reserve, which represents the cushion heartbeats available for exercise. The aerobic training heart rate range is calculated so that each person works between 60 to 70% of their range. In addition, patients are encouraged to carry out twice daily walking exercises and stair climbing exercises at home. Patients are advised to start with 1 flight of stairs and build up to 3 flights or 55 steps, like on the Jacob's Ladder in Sidmouth. All exercises are aimed to facilitate early post-operative ambulation and for patients to maintain their activities of daily living following surgery. Smoking cessation advice is provided to current smokers and, if required, nicotine replacement to help them quit smoking. Our patients come from a rural setting and from a vast geographical area. To facilitate provision of prehab closer to their home, a similar standardized program has been established at the patient's local hospitals. We have also taken advantage of the mobile unit facility provided by the charity Tenovus for us to do so. Based on our referral criteria for prehab and over a 2-year period, we have received 306 referrals from lung cancer MDTs across Southwest Wales, with equal proportions from each lung MDT. To study the impact of prehab program on cancer patients, we specifically excluded patients with benign or other conditions and patients who declined prehab, DNA'd, died, or proceeded straight to treatment. 216 patients with lung cancer were thus identified. Their mean age was 72 years, with an almost equal proportion of male and female patients. 77% of the patients had stage 1 or stage 2 disease. 20% of the patients were currently smoking. 60% had high dyspnea scores, 55% high performance status scores. 81% of the patients led a sedentary lifestyle, and half of the patients demonstrated moderate frailty. Their average FEV1 was 1.7 liters, TLC of 66.4%, 6-minute walking distance 306 meters, and average thoracic score 2.8%. Hence, 59% of the patients were deemed unfit for surgery. Following an average of 3.1 prehab sessions delivered over 39 days, there was a significant improvement in the overall dyspnea score of patients from 40% to 65%, in the performance status of patients from 45 to 62%. In the level of activity of patients, 81% of the patients referred for prehab were classified as leading a sedentary lifestyle. Following prehab, 81% of the patients were now either active or very active. Similarly, there was a significant improvement in the frailty index of patients, with 70% of the patients demonstrating no frailty following prehab compared to prior to prehab, and with improvements in the dyspnea scores and performance status. And consistent with our previously published pilot study, there was a significant improvement in the overall thoracic score of patients. Prior to prehab, 59% of the patients were considered unfit for surgery. Following prehab, 76% of the patients were now ready to proceed with surgery. And of the 216 patients, 150 patients, that is 69% of the patients, proceeded to surgery. Comparing patients who received prehab to those 60 patients who went straight to treatment, a higher proportion of patients who received prehab underwent surgery. 71% of these who received prehab underwent an anatomical lung resection. Following surgery, the median length of stay was 7 days, major complication rates 8.7%, and 1-year mortality 16%. Amongst those who went straight to treatment, a significantly low proportion underwent an anatomical lung resection. The length of hospital stay was significantly longer, averaging 9 days, with a trend towards higher complication rates. There were, however, no differences in the mortality rates between the two groups. Next, we focused on examining the impact of prehab on patients considered high risk on subjective criteria, namely those with dyspnea scores of greater than 3 and performance status greater than 2, and compared the outcomes with patients considered low risk who had dyspnea scores of 2 or less and performance scores of 1 or less, thus excluding patients with confounding factors of dyspnea scores of 3 and performance status of 2. On these subjective criteria, prior to prehab, 100% of the patients were not ready for surgery. Following prehab, there was significant improvement in all parameters tested, and 53% of the patients were now ready to proceed with surgery. Indeed, 43% of the patients went on to have surgery, albeit significantly lower than the low-risk group of patients. A significantly lower proportion of patients underwent an anatomical lung resection, and there was a significant difference in the approach used. Nevertheless, following surgery, there was no difference in the length of stay in the high dependency unit or the ward. There were no differences in the major complication rates or in the mortality rates between the two groups. Similarly, on examining the impact of prehab using objective criteria, or objectively using DLCO values of less than 50% and comparing with patients having DLCO values greater than 80%, we found that a significant proportion of high-risk patients, that is 79%, were not ready to proceed with surgery, compared with a low-risk group of patients. Following prehab, a significantly higher proportion, 59%, were now considered ready to proceed with surgery. Of the 33 high-risk patients, 55% proceeded to surgery. A significantly lower proportion underwent an anatomical lung resection, but there was no difference in the approach used. The length of stay in the high dependency unit and ward was significantly longer in patients with low DLCO values. There were, however, no differences in the major complication rates or the mortality rates between the two groups. Yes, our study has its limitations. For example, this was not a randomized trial. The numbers in the subgroups were small. Nevertheless, our study confirmed that a standardized, structured prehab program significantly helps to improve the dyspnea score, the performance status, levels of activity, and frailty index of patients, and thereby lowers the Thoracic score and the perceived increased risk of post-operative death and rates of adverse events. By doing so, Prehab helps to optimize a significant proportion of patients previously considered inoperable, allowing them to proceed with surgery safely with outcomes no different to those in the low group category. When we included patients with other pathologies into our analysis, although the results have not yet been published, the outcomes were similar. When implementing a prehab service in thoracic surgery, it is important to have clear aim and objectives for setting up the service. Published guidelines and experience helps enormously. A standardized service requires a team of trained cardiothoracic physiotherapists, adequate facilities and equipment, a structured program with regular assessment of patients as they go through with the program, and a setup tailored to suit the geography of the region. By doing so, a standardized prehab program helped to optimize the 81-year-old lady to undergo surgery safely for stage 1 disease. She stayed 5 days in hospital and suffered no major complications. I wish to thank Gemma Thomas and her team for setting up this service and the support we have had from our commissioners and the charity Tenovus for the use of their mobile facilities. I thank you for your attention.
Thank you, Ira. Very nice and eloquent piece of work here. Congratulations on these findings and turning around those patients and making them, suitable for surgery. And I know there has been a trend around the country for things. We here in Wessex have something called the WestFit, which has been readopted, the Safe Fit, to make people fit for surgery. And I think it's becoming more relevant to our practice now, especially with the increasing age of patients overall and the increasing number of comorbidities. So are you, from your conclusion, are you planning to start some sort of prospective sort of work on and some more expand this study?
Thank you, Eamon. Yes, that's a very good question. I mean, we have actually set this up since 2017, and we are continuing to collect the data. It's all collected prospectively. And as we sort of improve in the number of cases, hopefully we'll be able to make more out of what is actually happening. This is the initial feelers, so to speak, as to whether we are doing the right thing, are we on the right track? And it shows that, yes, we are. It makes a big difference. We've noticed that, we have quite confidently taken very high-risk patients through surgery. And hopefully, as we sort of increase the numbers, we can then sort of dissect it further and see, for example, by improving, using adjuncts, for example, nutrition, correction of anemia, etc., especially when it comes to correcting your DLCO values, whether that will have an impact and allow us to actually provide surgery to these patients more safely. So yes, the answer is yes.
Very good. And would you consider sort of expanding this beyond the Swansea Centre into other centres in Wales, at least, to see whether you can reproduce your good results in other centres?
That's again a very good question. As you're well aware that we are planning to centralise the thoracic surgical services to one unit, which will be in Swansea. And the aim, this is actually a stepping stone to expanding it across all of South Wales. Yes.
So I have a question here. How did you recruit the other? Okay. Well, what were the physiological markers improved with the prehab in this cohort? This is a question from, and there was another question I'm not sure whether it's related to us. How did you recruit the other centers and ensure standardized programs are carried out? Did you measure patients' compliance at home? So I'm not sure whether...
No, they're relevant, actually. They're very important questions.
Okay.
I think coming to the second one first, we initially set up this service in Swansea itself, because we had the gym there, we had the cardiothoracic physios there. And this was part of our pilot project, which we did earlier on. And once we had established the service in Swansea, we then went across to, say, for example, Carmarthen, and across in the east to Bridgend, and established similar sort of setup with the local physiotherapists there. But our cardiothoracic physiotherapists provided the expertise, for that special cardiothoracic physio which you require. And that's why the hub and spoke model, and we got that going quite successfully. We used the Tenovus mobile facility for Bridgend because patients wanted their prehab close to their home, which is fair enough. And the charity was very helpful and forthcoming with their mobile facility. And we found that it was actually pretty good, it was brilliant actually, and patients loved it. Then the home exercise program, yes, that is very much a part of our prehab service. However, we were not able to sort of really, assess that objectively because it was very difficult to sort of, assess the physios to assess that home exercise program. We just simply had to prioritize patients and, as they were progressing, we couldn't really keep them waiting and we had to just bring them in for surgery as quickly as possible. So that element was not really fully assessed. Coming to the physiology, yes, that's a very important question. I mean, we essentially focused just on dyspnea score, performance status, your level of activity, frailty. Those are the four main easily accessible parameters by the physios. We wanted to look at the lung functions and especially CPEX, but that required a lot of financial input, which we simply didn't have at that moment. So that is something which we couldn't do.
I have two more questions if we have time. One of them from Aman, how can you ensure that all patients undergo ERAS? And one other question, did you consider how the patients can travel to your center as some of them live far away from the hospital?
I think it forms an important part of ERAS, there's no doubt about that. Coming to the second question, I mean, that's a very good question. For example, our patients come from extremely, remote areas, and especially when you look at Pembrokeshire, that's quite far, and further up, in Ceredigion area. So what we actually did was, some of the physios actually went to their homes. They also actually made home visits and provided them with what you call exercises so that they could carry that out at home. However, those patients who required gym-based exercises, who were requiring a bit more physio, they had to be sort of brought back to the so-called spoke center.
And you arrange the transport yourself, sort of the day or through their GP service, is it funded, your service? Did you have any funding for it, or was it the patient had to make the effort?
Yeah, the patient has to make the effort. That bit is not funded.
Okay. Thank you very much. Any other questions from the floor? Great.
Thank you very much.
Thank you, Ira. Very nice. Beautiful study. Excellent. So I think, is there any major questions for the participants at all, for the attendees? I think we are coming to the end of our actual session itself. I think we wrap up at 3. So just a quick reminder to everybody, please visit our sponsors, exhibition. It's important that we show support because they have helped us set up this session and this virtual meeting. We rely very much on their support in keeping our annual meeting going. So please I know they've thrown some carrots there for us, an iPad, an iPhone, and some earphones. But just make an appearance, even if you're not taking part in the quiz, just to show some support. Thank you very much, everybody. All the best.
Thank you.
Thank you. Thanks.